in giving a presentation is never to follow kids, dogs, or superstars. Unfortunately, that's what I'm having to do today. I don't think you realize most of us would not be in this room, would not be doing newborn screening if it wasn't for that man right there, Dr. Harvey Levy. I hope you really get a chance to see him afterwards, talk to him, because he is really one of the superstars in this field. Before we get started, I found something interesting while I was researching for this talk. And that is the problems of the current shortfall in funds, which I know you're probably all aware of. Well, we had the same thing in 1964 when we began newborn screening. Things were different 50 years ago, though. There was talk and a big discussion about how many people were going to have to lay off, how many labs were going to have to close. And the amount the laboratory had to absorb in 1964 was $60,000. It would be great if that's what kind of reductions we had today. I'd like a show of hands. I know we're a real diverse group. Can I see a show of hands of those county health nurses that provide direct patient care, particularly in newborn screening, those that draw blood, that refer patients and all that. Can I show of hands? Great, great. These are the kind of people that were there in 1964. From the state level at the lab, we had 5 people. So this is where our personnel was set when we started the programs. And now what we're going to do is we're going to take a little journey into the past. The world of public health was very different 50 years ago. The protocols and standing orders that you operate under now did not exist. Few people knew about what newborn screening was even all about, why we were there, what we were going to do, what guidelines we were going to have. And so we had to kind of make our own rules as we went along. There were no federal, no state, no department regulations that covered newborn screening. We embarked on a great journey together and to identify and control a group of deadly disorders without any map, any guidance. So we decided first to focus on PKU. PKU had been identified 30 years earlier in 1934. In fact, this is one of the labs. This was the lab that was set up in Colorado where some of the work was done in those early days. As Dr. Levy had stated, it was carried by autosomal recessive trait caused by the enzyme phenylalanine hydroxylase not being present. So phenylalanine does not get changed into tyrosine. Phenylalanine hits a buffer, a barrier when it tries to go to tyrosine, so it diverts itself to other pathways. The end result is that phenylalanine builds up in the blood and phenylpyruvic acid and some other metabolites. And that blood level rises until these metabolites are excreted in the urine. In 1957, the Ferric Chloride Diaper Test came about. It was developed, and then not too many years later was another product called Phenystick. Both of these used infant urine for testing. They were easy to perform in birthing centers. They did not require an exterior laboratory. So there was, in particular in this state, quite a bit of use of ferric chloride type testing. The unfortunate problem with this is that these tests only become positive quite a ways after the time that brain damage has occurred. So nice start in the testing, but just not really good. In fact, our second PKU we found was a negative Phenystick, but when we looked at the phenylalanine level on this child, it was 63.7 milligrams per deciliter. Translation, very, very positive. Nevertheless, many hospitals used this test in the early 60s. And some of you might be wondering why I put this on the slide. If you see a child like this in your clinic, don't really worry about PKU. Worry about the parents. what Dr. Levy talked about. 1960, Dr. Guthrie developed a laboratory test that would detect PKU before the harmful effects could become apparent in the brain. In 1964, the laboratory sent 2 employees to Massachusetts to train to perform the PKU test. Massachusetts lab was also kind enough to give us several vials of the Bacillus subtilis spores, the mutant bacteria that was used in this test, so that we could do some evaluations and that we could also have some left over that our microbiology lab could grow up the spores so we'd have continuing reagents throughout the course of our studies. Again, remember back in those days, there were no FDA-approved kits. The FDA really didn't act in the laboratory work at all. So we had to develop our own test. We had to read the scientific papers. We had to figure out how the test was run, either that or go to, like we did in another state, and see how they were doing it, and then try to make sure we got it all working and we got the same results as everybody else. This dilemma and inherited non-uniformity in testing methodology, because all of us varied a little bit to make it work in our own area. And I can remember one time looking at a paper, I was going through trying to get something to work, and one of the ingredients was 1-normal HCl. I ran into the person in the meeting and said, why did you use this? Because we didn't think that really worked too well. We had to adjust that. Oh, the reason I did that is because that was the only thing up on the shelf when I was doing my experiments. So the test all of a sudden started varying slightly from state to state, region to region. And this would later be solved for those of us on the Newborn Training Committee of the Lab Directors Association when we sponsored symposia for laboratorians to get together to exchange data and look and see how they were doing the test, how we were doing the test, and kind of by all kinds of networks, all of a sudden the test started becoming very uniform across the United States. Back in the 60s, we also needed known positive and negative samples to make our test work. Other states would share reagents, like Massachusetts gave us those mutant spores. Positive is too precious. We were just starting out. There were very few PKU babies. They were just, we only got so much blood in. I'm sorry, we're not going to be able to give you any. So we sat around and said, let's develop a laboratory test. We want to do that. Let's see how we can do it. And so we decided where would be a place that we might find some positives so we could get some blood to start our test. The meeting came out and we decided probably Prattville State School and Hospital in Tuscaloosa would probably be one area where we might find one PKU. Find one PKU, then we can get our blood, we can start our test, start offering it to the general public, and start screening newborns. In October '64, a team of 5 went to Prattville. We collected blood from 2,100 patients. We found not one, but 18 positives. And we discovered something else. Not just testing would be important, but education would be another component that really would be important in newborn screening. The reason is 7 out of those 18 were from 3 families. One family had 3 siblings, and then there were 2 families with 2 siblings each. We could actually have a very good impact upon PKU if we had an education program to educate parents that had a PKU child. Here's Prattville's thing. For those of you that remember Prattville, they're now closed, but I'm kind of glad that you didn't have to go there. Some of it was a pretty depressing place. Not for PKU, although that was depressing. There were some severe abnormalities there, physical abnormalities that were sometimes difficult for us to deal with. We got to see our firsthand the devastating effects of undiagnosed and diagnosed PKU. Slide that Dr. Levy had. Most of the individuals that we looked at and drew blood from had severe cognitive deficits. And collecting blood from an adult that's having a tantrum is not the most fun thing to do. If we'd only taken some county health nurses with us, we probably would have had a much easier time. And in fact, I'll never forget the day that I had set up a mobile lab testing, lead testing unit in the Dallas County Health Department in Selma. I saw firsthand what nurses go through when into that small room where I was occupying with the machine was a screaming young boy who had wrapped his feet and his hands around the door frame, and the nurses were trying to get him into the room. The mother was standing right behind him yelling, "I told you it's going to hurt. I told you it's going to hurt." Bless you, nurses. Bless you. Here's the Guthrie plate. This is not one of ours, but one that I found. We also found our first positive that year. Out of the first 500 specimens we processed. And this is what a Guthrie PKU test plate looks like. You can see the controls at the top with varying, increasing volume, amounts of phenylalanine. And then if you look right, left, to center, you'll see a positive. These early days were really challenging to not only the lab, but physicians. There were infants we found with elevated phenylalanine levels that they had a really unclear diagnosis. So therefore there was requests for blood, requests for blood, requests for blood, requests for blood, and I know some of the physicians in those early days were not real happy with us. We also found out that educating these physicians not to place these babies on low phenylalanine diets was really important, because then we would get a baby in that would be 4 milligrams percent, just slightly elevated. We could see a little fuzzy spot around the spot. We'd send saying, let's have another specimen back so we could see what it is. The specimen would come back and it would be 0. And when we'd call, we'd find out they'd put them on a diet. When you don't get an essential amino acid into your body, what happens? You die. So you're constantly balancing between reducing the harmful effects of too much phenylalanine and the effects of no phenylalanine. It's kind of like Dr. Levy was saying about it not being formed in the body, and it's very important that we see that. And for example, another animal, the little common domestic house cat, there were some celebrities out in California, and they were vegetarians, and they were going to make their cats vegetarians. A lot of dead cats, because even worse than us, they're an obligate carnivore. They have to have, for example, lysine and taurine. Taurine is something we can make, cats can't. Dead cat. We also had problems in the early days with the physicians not being quite in tune with PKU disease. And so when you would call with a true elevation, you would either get problems with the staff not wanting to get the physician on the phone because he was seeing patients, he didn't have time for you, or he would get on the phone and be nonchalant. You know, doctor, I have an elevated PKU, we need to request immediately. Yeah, okay, thanks, click. Then we had a lottery. We would make bets about how long it would take him to finally get around to go into his office and reading about PKU and making a frantic phone call back to us. And it happened over and over and over until finally, amongst the physicians, they started realizing this is an important disorder. This is something we can treat, something we can prevent, and we better get on the thing and get on fast, get specimens in, and get these babies referred for treatment. The next year, in 1965, we started in 64, 1965, we found 3 newborns. By 1966, the newborn screening level for PKUs had driven to 68,960 specimens. So we've gone from 500 up to pretty much the entire population of Alabama. Another Prattville patient was found. We found 2 PKU newborns that year, and we realized then it was going to take a while before we would stop having new admissions to Prattville. 67, 1 Prattville PKU out of 141 admissions. So we were still getting these older children who were having deficiencies and being referred to Prattville. 68 next year, 1 more Prattville PKU and 55 admissions, and 1 newborn. In 1968, we expanded the Guthrie test to include tests for tyrsinosis, MSUD, and homocystinuria. Using the new test, we found a baby with homocystinuria. We went back and looked at 1,970 Prattville patients, and we found 2 previously unknown cases of PKU, and we found 1 case of hereditary tyrsinosis, and 1 case of a previously unknown disorder of sulfur metabolism, which I don't think I've ever gotten the results on that. Somewhere in the 60s, we needed data on something called the phenylalanine loading test. Information was sparse at that time, and we needed controls, and so we got volunteered. I learned several things that afternoon. 1, phenylalanine mixed with orange juice looks metallic. So it looks like you're drinking paint, metallic paint. 2, you feel hot. 3, you get really irritable about the people going up and trying to change the thermostat in the room. And 4, you find out that the bathroom starts to smell like 1,000 mice have taken up residence. So I got a brief period to know what a high phenylalanine level in the brain feels like. Homocystinuria in 1970, we discontinued. This is not any of our patients. We discontinued the MSUD, tyrsinosis, and homocystinuria testing after 126,000 specimens were tested. It yielded only 1 case of homocystinuria. The family of that infant refused further studies, and unfortunately the baby passed away. Also in 1970, we found 4 newborn PKUs. Next year, 1 newborn PKU, and no PKUs in Prattville admissions of 195 patients. The next year, 1972, 2 PKUs newborn, no admissions to Prattville. 1972 was also the year we instituted the abnormal hemoglobin screening program. After developing a filter paper collection method for several years, we started this particular test. Unfortunately, in those days, there were no commercial kits available, like I said. So we had to go and find some military surplus power supplies. These supplies did not have any safety control. So you could always tell when we were testing because inadvertently, it was guaranteed that sooner or later you're going to pick up one of these electrophoresis plates and get zapped with a whole bunch of voltage. So all around the lab, you could tell when the people were doing hemoglobinopathies because there was ow, ooh, ow, ooh, ow. You know, so. (1973), 9 years into the program, 3 newborn PKUs, 0 Prattville admissions. The next year, 10-year anniversary, 7 PKU newborns, 0 Prattville admissions. We finally got together and decided that we would declare the newborn screening program a success. 10 years after the program began and 6 years after that first Prattville admission, we felt that adult children would no longer be present in our state at least if they were born in our state and screened in our state. The need for national standards, we still didn't have them. We still didn't have the standards that we needed in the protocols and the guidance needed for this program. It led to a working group that met in Rensselaerville Institute in East Central New York State. Beautiful, isolated state park. Got invited by Ken Pass to come up there. There were 5 of us. He didn't tell us until we got there that we were going to be prisoners. And he was not going to let us leave that state park until we came up with national newborn screening standards for collection, shipment, testing, reporting, confirming, treatment, and monitoring newborn screening patients. So that was the start of the documentation needed for newborn screening. These early years were exciting periods. It was the Wild West. It was a time of development and applying new science. That period ended when we matured, and we matured into a standardized program for detecting an ever-growing list of inborn errors. The Alabama program is a success. I went from looking at a 50-year-old man in a diaper who couldn't control his bowels with an IQ of 20 standing in a room in Prattville to one of the early PKU children that we found that was diagnosed, put on treatment, and graduated from school with honors. All of you in this program are very special. I don't know if you know it, but when your career's over, you'll be able to say, I was part of something important. I was part of something that dramatically made dramatic changes in people's lives. You can look in their back that you did something special. And there's very few people in this world that can say that. Oh, one more thing. While I was doing some research, in the year that we found this, I ran across some other slides. And this is for the nurses. All the rest of you are not affected. But please tell me this is not one of our nurses. Huh? Thank you very much.